Alright, we're back with our third section on the urinary system, and now we're really going to start getting into the functions of actually what goes on in which part of those nephrons. A lot of what goes on here, when it looks, when we're looking at reabsorption of things, whether it's glucose, whether it's amino acids, whether it's really much of anything inside the kidneys, is going to be driven by active transport. And when we talked about active transport all the way back in chapter 4, a couple of things we said about active transport was that A, you have to have some type of transport protein, and B, you have to be willing to spend some ATP to do it. So both of those two things together, the fact especially that it requires the use of transport proteins, means that there is a point at which you really can't move any more of the substance back into circulation. So there's a maximum rate of transport. Once all these proteins are saturated, once they're all working at capacity, then you simply cannot move more things back into circulation from that filtrate. Now, when you look at what happens with a diabetic patient, a patient who, especially a type 1 diabetic patient who has too much glucose in the blood because they're not producing insulin to get it out of the blood into the cells of the body, the glucose is eventually going to end up from the blood into the kidneys. And so if that person is unable to reabsorb all the glucose back into the blood, there's a really good chance that could occur after a carbohydrate-rich meal. They simply might not be able to move all the glucose from the filtrate back into the blood. You're actually going to start losing glucose in the urine. And so as a primary means to detect diabetes, if you see a patient that has glucose in their urine, that's a fairly good indication that they've got far too much glucose in the blood, far more than what they should have, perhaps because they're not producing insulin or because the insulin isn't working due to the receptors that might have been reduced in number over the years for type 2 diabetes. From there, we actually have the secretion of the waste products. There's going to be movement of things, and again, these are excess ions, excess nitrogenous waste, excess H pluses across the capillary membranes and into the filtrate itself. So that's going to eventually become what we call urine. When you look at something like penicillin's a medication that historically, when it's administered for patients, has to be given several times a day in very, very high doses because the kidneys are actually pretty good at getting rid of it. So you might take 800 or 1,000 milligrams of penicillin and really only see a tiny fraction of that relatively because the kidneys are moving a lot of it out of the body in the form of the urine. So you have to repeatedly dose a patient with penicillin in relatively high doses with the assumption that, hey, well, most of this isn't ever going to get to the point where it can fight infection anyway. Most of it's going to be wasted as the urine is produced. So the main part of the kidney is the excretion part, and we do have a lot of the things we talked about before: excess water, nitrogenous waste like urea, excess potassiums, excess H pluses, excess sodiums and chlorides even could be excreted as well, removed from the blood and not reabsorbed. So they're going to help get out of the body by the kidneys. And like we mentioned before in one of our previous sections too, the kidneys are also involved with maintaining acid-base balance of the blood because of the ability to get rid of H pluses. If the blood is relatively acidic, the kidneys can filter out more of the H pluses, not reabsorb them, pass them out of the body in the urine, and for that reason bring the blood pH back up to a somewhat more normal level, or a place where it needs to be, with that critical range of where we really want to keep our blood pH. So that's the function as it pertains to getting rid of H pluses. Bicarbonate ions can also be returned to the blood during reabsorption. So bicarbonates, again, one of those things we talked about with involvement in the maintenance of the blood buffering system for pH, acids, bases, and so forth. Those bicarbonates can be filtered out of the kidneys at the tubules, but they can also be reabsorbed. We can also get rid of excess H pluses like we talked about previously as well. So, urine is typically somewhat acidic. It's going to be in a pH range of maybe between 4 and 5, maybe 6. Relatively acidic, not hugely acidic, but certainly more so than the blood would be. Most of the nutrient molecules that might be filtered out of the blood are going to be returned back into circulation. Most of the salt water is as well. So one of the things that we're going to see is what the kidneys are doing is they're pulling out sodiums, they're pulling out chlorides, and they're pulling out water, kind of more or less in that order. And as that's pulled out of the blood, it's eventually going to be returned back into the blood because you want to hang on to most of those sodiums, most of those chlorides, and most of that water. What we're doing here is we're creating a pathway for other kinds of things to be filtered out of the blood as well, Sodium chloride and water goes along with it, but typically those last three things also get reabsorbed back into the bloodstream. Like I mentioned a second ago too, sodium chloride and water are taken out of the filtrate in roughly the same amount. We see the two ions go together, sodium ions, chloride ions kind of go together, and wherever they go, water is going to tend to follow it. The filtrate in the tubule from there is relatively isotonic until we get into the distal convoluted tubule. So what we're looking at right now is the proximal convoluted tubule. Most of the reabsorption that takes place of nutrient molecules, most of the reabsorption of the salt water takes place in the proximal tubule. And again, this is the section of nephron that's right after you go through the glomerulus. We talked about salt water as well. At this point in the proximal tubule, the filtrate is going to be relatively isotonic as compared to the blood plasma. We have not yet gotten to the point where the blood is relatively hypertonic, but we're going to. We're kind of heading that direction. Now the distal convoluted tubule, we have filtrate coming in that's relatively hypotonic compared to the environment around it. Distal tubule is over here. So the filtrate inside of here is relatively hypotonic as compared to the environment around outside the tubule. And so what that's going to do is it's going to create, because the interstitial fluid outside in the medulla is hypertonic, there's going to be a movement of water. Water is going to go out of the collecting duct, out of the distal convoluted tubule, and into the surrounding interstitial fluid. You imagine here inside this tube, if there is more water relatively proportionally than there is outside the tube, then water is going to go from inside the tube to outside the tube. And what does that mean in terms of consequence for water conservation? Well, any water that leaves the tubule then is not going to leave the body as urine. Any water that stays in the tubule will leave the body eventually as urine. So the more water we get out of this tubule along its length, the more water we're going to end up conserving. The less water we're going to use, I guess, in other words. Now, the distal tubule is the primary port of control for that antidiuretic hormone we talked about back in the chapter on the endocrine system. Antidiuretic hormone, what it does is it helps to increase the number of aquaporin proteins in the lining of this distal convoluted tubule. And aquaporin proteins are the ones that help to facilitate osmosis. The more of those proteins you have in the walls of this distal convoluted tubule, the more water you're going to lose from the tubule. It's going to go out of the surrounding tissue, and for that reason, it's going to be conserved. So one of the effects of ADH is to increase the production of aquaporins in the walls of this tubule to help it reabsorb more water. If you decrease ADH or add one of the antagonist hormones, then the effect is going to be to take away those aquaporins. If the water now has less ability to get out of the tubule, it's much more likely to stay in the tubule and eventually pass on out of the body. We talked too about electrolytes, right? Sodiums, potassiums, calciums, chlorides, those kinds of things too are involved with both reabsorption and secretion too. So some of the main ones, also bicarbonate, didn't mention that one a second ago. That one is an ion also, which can also be reabsorbed and or secreted depending on how much of it might be present. So we look at blood volume, we look at blood pressure, we look at blood osmolarity. Hormones are all involved here, helping to maintain homeostasis for all of those things. And all of those things are very, very important inside the body. You want to make sure you have the right solute concentration, the right blood volume, the right blood pressure. If it's too high or too low, then you run the risk of organ damage or passing out if it's too low. So you want to make sure it's the right level. It's also involved in regulating those ion concentrations we talked about and blood pH within fairly narrow limits. So there's a lot of hormone functioning going on here. We saw before we have ADH. We've also seen ANH. We've also seen aldosterone. And all three of those hormones are involved in one way or another with maintaining the right osmolarity of the blood, the right blood pressure, and the right blood volume. So ADH, again, we saw this before. We're just going to kind of review it quickly. Primary stimulus for ADH is dehydration. So if the blood volume is relatively low, or if the blood osmolarity is relatively high, so you got to imagine if you're dehydrated, if you've lost a lot of blood, there's going to be relatively more solutes left behind. So the blood is actually going to be more concentrated when it comes to different things that were dissolved in the blood. You have less water in your body, so you have therefore proportionally more solutes in your body. And so if the body can detect that, if the sensors, if the osmoreceptors in the hypothalamus detect that, then they're going to send a signal to the posterior pituitary, causing a production of increased ADH. And of course, ADH allows the kidneys to reabsorb more water, and reabsorbing more water helps to conserve water. The other thing that it does here is it also drives the thirst reflex. So the osmoreceptors in the hypothalamus also help tell the brain that you're thirsty, and they're going to cause you to want to take a drink once you become dehydrated, automatically, without you even having to think about it really. You're thirsty after you're dehydrated, so you're going to tend to drink water after you're dehydrated. So this one, again, is primarily the result of increased osmolarity of the blood. Water has left, solutes are still there, the blood is therefore more concentrated. And the effect of ADH, again, like we talked about a couple of minutes ago, is to make the walls of the kidney tubules more permeable to water and to solutes. And if that occurs, then you're going to have more things filtered back into the blood from the kidneys, from the tubules, than if you didn't have ADH being produced. So more ADH allows for more reabsorption of water in the end. And therefore, you conserve water. You're going to lose less water. You're going to produce a lower urine volume. It's going to be more concentrated, more solutes in the urine. But it's going to also help you conserve water, which is kind of the main point of doing this. Now, aldosterone is a different hormone. It's one of the two antagonists. Well, actually, not really. It's more of a cooperator with ADH, and antagonist to ANH, or atrial natriuretic peptide is the other one. Aldosterone is produced by the adrenal cortex, and its primary stimulus is lower than normal levels of blood sodium. Now, think about what happens when you get really hot. If you're in conditions that might lead you to become dehydrated, there's also a really good possibility you're going to be losing sodium ions because you're sweating, right? You're getting rid of excess water that way. You're also getting rid of Na pluses that way as well. And you have to have Na pluses for your body to function at all. So when your concentration of Na pluses in the blood goes down, then you're going to have a couple of things happen here. We talked about these back in the chapter on endocrine system. Number one is the distal convoluted tubule is going to become more permeable and more sensitive to sodium ions, so that any sodium ions that might be in the tubule still at that point can then be reabsorbed. They're not going to be passing on out of the body because you already don't have enough, and the last thing you want is to be peeing out more sodiums when you're already lacking some of them to begin with. The other thing that happens here is that when you start reabsorbing sodium, you're going to start reabsorbing chloride ions. Sodium's got a plus charge, chlorides have a minus charge. If you start pulling sodium ions out of the tubules into the interstitial fluid, then chloride's going to go with it. And at that point, you have sodium chloride out there in the surrounding space around the kidney tubules. And of course, once you have that, water's going to follow as well. Water's going to go wherever the ions go because of osmosis. So what you've done is you've taken the external environment outside the tubules, you've made it hypertonic. Water's going to want to leave the tubules and follow those solutes to help make things as isotonic as possible. What that means then, because the water is now out of the tubule into the blood, is you've actually been able to conserve some water. So that's going to be kind of a big help as well. The other thing that's kind of an effect or a factor here is that when sodium levels are low in the blood, there's also typically going to be a lower than normal blood volume as well because you're dehydrated. You've lost blood water. There's more solutes in the blood, but a lot less water. More solute proportionally, but a lot less water, so you're going to tend to have a lower blood volume, blood pressure is going to drop, and again, that could be kind of a bad thing. So all of this is part of what's called one large system that helps maintain your capacity to operate, especially in hot, dry conditions, called the renin-angiotensin-aldosterone system. All three of these things are going to help you maintain consciousness and maintain water balance in situations that might otherwise lead you to become overly dehydrated and maybe even die as a result. So that's something else maybe talk about a little bit later, but for right now, that's about all we're going to say on it. Again, this is kind of the effect that we see here with, let's see, that renin-angiotensin system we talked about a second ago. We have a stimulus here of low blood pressure, and because you have low blood pressure, that's going to lead to low blood flow. Low blood flow is going to be detected by sensors in the juxtaglomerular apparatus here surrounding the glomerulus near the Bowman's capsule. The pressure sensors here, if they're not stimulated enough, that's going to be kind of the signal that blood pressure is relatively low. That's going to trigger the production of renin. Renin is going to trigger a production of angiotensin through the production of angiotensinogen. So like we saw before with pepsinogen being converted to pepsin, now we have angiotensinogen converted to angiotensin 2. This hormone then has the ability to trigger the adrenal cortex to release aldosterone. The adrenal glands kind of sit up on top of the kidneys, sort of like a little hat. The adrenal cortex can produce aldosterone, which then causes the kidneys to do the things we talked about before. We're going to cause the distal tubules to increase sodium chloride reabsorption, and as a direct result, water absorption as well. And that's going to help us increase blood volume. And once blood volume is back up to a high enough level, the sensors in the juxtaglomerular apparatus are going to be happy, and they're going to start slowing down or even stopping the signal for the production of more renin from its producer as well. All right, another hormone that we can look at is ANH, atrial natriuretic hormone, or otherwise called atrial natriuretic peptide. This one is the antagonist to both aldosterone and ADH. It's going to cause diuresis or production of more urine. It's going to increase urine output. This hormone is produced by the right atrium of the heart, especially when there is an increase in blood pressure, because one of the things that having too much blood volume will do is it will increase your blood pressure. So pressure sensors in your right atrium detect this. They're going to start secreting ANH, and that's going to cause excretion of salt, and with the excretion of salt, there's going to be also excretion of water. Okay, so you imagine here, now the tubules are less permeable to sodium ions, less permeable to chloride ions, and less permeable to water as well. So you're going to have more ion loss and more water loss in conditions of overconsumption of water than you would under conditions of, say, like dehydration. Right? All right, so two other things unrelated to what actually goes on with the urinary system. There is production of erythropoietin. Kidneys are also involved with producing erythropoietin, which we've seen before in our chapter on the circulatory system. These, of course, this function, of course, results in the production of more red blood cells from the red marrow of the bones. So like we saw before, if blood oxygen levels are chronically low, what can happen is that the brain can actually signal erythropoietin to be produced and released by the kidneys, which will then produce more red blood cells from the bone marrow, red bone marrow of the skeletal system, at which point then you'll start to have a better capacity to carry O2 because you now have more red blood cells circulating. So that's another really important function of the kidneys. We can also look at the transformation of vitamin D into its active form, and once you have that, you can have more absorption of things like calcium and phosphorus, two very, very important elements involved with keeping you healthy as well. So that's another function of the kidneys. All right, so we're going to stop here, and I will start up the final section here momentarily.